environments in which we see older adults. And we are charged with an awesome responsibility. It's a privilege for us to take care of older adults. I have no significant financial disclosures or conflict of interest. However, this presentation and many of these slides are supported by a grant from the Health and Human Services Department of from HRSA, which stands for the Health Resources and Services Administration of the U.S. Department of Health and Human Services. So, what are our objectives? By the end of this talk, the learners, that's us, we should be able to define geriatric syndrome. In addition, we should be able to define dysphagia and identify some of the factors contributing to dysphagia. In addition, we should all be able to describe these specific geriatric syndromes of undernutrition and obesity. And finally, to identify the diagnostic and therapeutic approaches to the management of nutritional disorders, undernutrition and obesity. So here's a question. This is a very relevant question. Which of the following is a sign of aging? A, increase in the pigmentation of hair. B, increase in bone and muscle mass. C, increase in body fat content and intra-abdominal fat stores. And D, increased kidney function. So in the older adult, there's a decrease in pigmentation of the hair. There's a decrease in bone and muscle mass, skeletal muscle mass. The term is sarcopenia. D, there's a decrease in kidney function. So the correct answer is C, increase in body fat content and intra-abdominal fat stores. And that's important because those changes, those age-related changes have implications. They have clinical implications. For example, changes in the kidney function, a decrease in the kidney function, a decline in creatinine clearance, it can affect our prescribing habits, right? So it can affect, and it should affect, because we need to adjust for the dosage of medications. We need to adjust for the frequency of medications, because many medications are eliminated through the kidneys. In addition to that, the volume of distribution of medications is impacted by the body fat content. So all these age-related changes have clinical implications. If you notice here, it says decreased taste sensation. So an older adult may present, in terms of the HPI, the history of present illness, may present with complaint of changes in taste, right? A decrease in the ability to taste. And notice I'm saying a decrease in the ability to taste or a decrease in taste sensation and not taste discrimination. And what do I mean by that? So an older adult maintains the ability to taste and to discern between, let's say, sweet and salt. But the problem may be that a higher dose of salt or a higher concentration of sweet is necessary for them to identify that particular taste. As we age also, our ability, how we swallow, the swallowing process is slowed. Okay, so that's important. And that helps us differentiate between the causes of, let's say, swallowing disorders or the causes of dysphagia. For example, an older adult, if you're assisting an older adult in eating, someone may notice that that particular patient at lunchtime still has residual food in the cheeks, right? That is one particular, that is information that leads us to one particular diagnosis. And that is different than an older adult who's complaining of pain when swallowing or difficulty swallowing, like sensation of food stuck in the throat when swallowing solids, as opposed to a different presentation of difficulty swallowing both solids and liquids. So these age-related changes have clinical implications. And specifically, when I speak of volume of distribution, when we speak of decline in kidney function, these changes impact our prescribing habits such that standardized nutrient requirements and the way we prescribe medications, those guidelines that apply to younger or middle-aged adults should not be or not be generalized to the older adults. Okay, this is a very interesting case. I deliberately picked it because it encompasses a lot of the problems we can see in an older adult, a lot of the nutritional problems, right? So here we have a case of a 74-year-old female. She's a widow, history of hypertension, borderline diabetes, and this is type 2 diabetes. Remember that diabetes type 1 is an absolute insulin deficiency, whereas type 2 diabetes has more to do with insulin resistance. And that's important because the management, diet and exercise is first line, always, um, followed by oral agents, that's an option, and followed by insulin. So those are options for type 2, whereas in type 1, it's only insulin. So we have a 74-year-old patient, widow who has a past medical history significant for hypertension, diabetes type 2, and osteodegenerative arthritis affecting her knee. She comes to her primary care physician for a routine checkup approximately a year after her husband's death. So that has implications too, okay? She's been married for a long period of time, and now she's alone in the house, okay? Is there any kind of mood disorder? She lives alone and she gets 2 to 3 visits per week from her children and members of her local church. She reports a 2-year history of knee pain, bilateral, both sides, knee pain, without associated knee joint swelling. So the joint swelling, the redness and warmth is not present. And those are indicative. Joint swelling, redness, warmth, even tenderness. Those are cardinal signs of inflammation. So this would be a non-inflammatory arthropathy, right? So it's osteodegenerative arthritis. So she reports 2 years of bilateral knee pain. Okay. She also reports numbness in her hands and her feet. Okay. And a 16-pound weight gain in the past 6 months. Numbness in the hands or feet. What's the differential to that? So in her case, um, is it related to diabetes? Diabetes has macrovascular complications, okay, cerebrovascular disease. It has microvascular complications, such as, so we have students here and we have fellows. What are some of the microvascular complications? Let's make this interactive. What are some of the microvascular complications of diabetes? Micro.
Maybe Renault or something.
Renal, did I hear renal? So nephropathy, yes. What else?
Retinopathy.
Retinopathy, nephropathy, and there's one more, which is very important.
Neuropathy.
Neuropathy, right? So she has some kind of numbness in her hands and her feet. Is this related to neuropathy, peripheral neuropathy, hands, stocking gloves, or is it related to micronutrient deficiency, such as is there any vitamin deficiency that can lead to any kind of paresthesias or numbness? So B12 deficiency, okay, and or maybe some kind of nerve impingement syndrome, right? So there's a broad differential for her presenting complaint with a numbness, okay? She also has a 16-pound weight gain in the past 6 months. She laughs appropriately to the joke, okay? On physical exam, her affect is appropriate and her mood is good, okay? She's 5'2", and she weighs 203 pounds. So that corresponds to a BMI of 37 kilograms per meter squared. She uses a rollator to assist her with walking, okay? So here's the question. Her history and physical exam is associated with which of the following? A, increased risk of functional decline. B, increased use of healthcare resources, healthcare expenditure. C, increased mortality. D, poor diet quality and micronutrient deficiency. And so potentially all of the above are correct, okay? Increased risk of functional decline, decreased mobility with arthritis and obesity, increased use of healthcare resources, and increased morbidity and mortality from macrovascular, microvascular, and poor nutrient, okay, B12 deficiency and other things. So all of the above potentially are correct. So what is a geriatric syndrome? It's a straightforward definition. A syndrome, and in this particular case, a geriatric syndrome, is a constellation of signs and symptoms. So it's a group of signs and or symptoms that occur in the older adult at a rate that is more frequent than they tend to occur in the younger adult. And these signs and symptoms, they characterize a particular abnormality or a condition that, again, it happens more frequently that is likely due to chance alone, okay? they occur, the signs and symptoms, they tend to happen, they occur simultaneously. And it's important to remember, especially when we're dealing with older adults, signs and symptoms includes emotions. It includes actions, okay? And these emotions and actions, in terms of being syndromic, they formulate a pattern that's identifiable, okay? So in terms of geriatric syndromes, this is a list. This is part of our curriculum. And these are some of the syndromes that we covered throughout the academic year. Okay, today I'm going to touch very briefly on dysphagia, and then we'll focus more so on nutrition, malnutrition, which has to do with nutrition and weight. This is a very important slide. And this slide, I believe, should be present in every single presentation. Why is this relevant? Why is anything that we do relevant? Why is it relevant? All the interventions that we do as physicians, anything that we prescribe, why is it relevant? It's relevant, and I say this, and not cliche, but it's relevant because, you know, we're not so much concerned about feelings or opinions per se. We are concerned about, or we practice evidence-based medicine. Okay, we employ an evidence-based standard of care. What does that mean? It means that all our assessments, any assessment that we do, including diagnostic approaches, any test that we do, and then the interventions that follow that, okay, all assessments and intervention should improve quality of life and life expectancy. They should improve quality of life and life expectancy. And another way of saying that is it should translate into a decrease in morbidity and mortality. Okay, and this is an important point that we should not overlook. Everything that we do, particularly in geriatrics, should be guided by the 4Ms framework. Okay, one of the key, or one of the primary or the key guiding principles of geriatrics and of, you know, medical ethics is that we ought to respect patients' autonomy. A patient has the right to decide or to dictate what happens to his or her body. Okay, a patient dictates what happens to his or her body, what treatment he or she is going to accept, what treatment he or she is going to decline, and that is all part of informed consent, right? It's not paternalism. It's not paternalistic medicine. Okay, it's not that the doctor says so, or the healthcare provider says so, or the NP says, or the PA says so, and therefore that's what it has to be. Okay, we work with the patient. It's taking the time out and taking time to understand the patient's wishes, and it's taking time to formulate a plan of care, okay, that aligns with the patient's goals and wishes, and then putting that plan of care into effect in order to impact healthcare outcomes, or in order to get the best outcomes for that patient. So what matters to the patient is essential, okay, and that's a major part of the 4Ms framework. We also consider medications, because medications and polypharmacy has significant implications in older adults. Functional status and mobility is huge. That's the other M for mobility, and mentation. The presence or absence of things like depression and delirium and dementia plays an integral role in terms of planning or deriving the patient's plan of care. So why is this relevant? Because we practice evidence-based medicine, and one of the best ways to do it in geriatric medicine is to let it fall under the umbrella of the 4Ms framework. A part of our assessment and interventions improving quality of life and life expectancy also means that there are times when we detect conditions and the intervention that's employed will lead to a fast or a quick improvement, or faster, quicker healing. Okay, so what are nutritional syndromes? And let's think about that for a second. What are nutritional syndromes? In terms of nutritional syndromes, uh, I'm thinking of malnutrition. Okay, and what is malnutrition? Mal is bad nutrition, right? Malnutrition. I think in order to answer that question, it is important for us to understand what is nutrition first and foremost before we can determine what's bad nutrition or malnutrition. So basically, what is nutrition? Nutrition is whatever we eat, really, in terms of things that we eat to ensure a healthy body, healthy growth, right? And just in terms of promoting good health. So nutrition is our intake to maintain a healthy body, or to sustain life, and to promote good health. And so it usually falls in the category of macronutrients, some of the carbohydrates and fats and things like that, or micronutrients, which include, vitamins and minerals. And then there's fluids, right? Water in particular. So our nutritional requirements fall into three main categories: macronutrients, micronutrients, and fluids. Now, on the right side of the slide, there's a diagram of what's supposed to be my plate for older adults. When we talk about nutritional requirements, we like to think of, for lack of a better phrase, a balanced diet, right? So, and many of us are familiar with the food guide pyramid, right? The food pyramid. So the My Plate is sort of a modified food pyramid for older adults. Okay, and it has recommendations as far as the proportions of macronutrients and micronutrients and fluids that's recommended for just healthy intake. Nutritional requirements. This is an important slide. This is an important slide because it points out something that's very interesting and often overlooked. Okay, age-related changes in our body, and this is normal healthy aging. Okay, age-related changes affects the amount of energy that our body requires. So age-related changes impact energy requirement. The basal metabolic rate, that is in essence the amount of energy that the body burns while we're resting. So the basal metabolic rate, or the BMR, or the resting energy expenditure, that is the main, or the key, or the principal determinant of the amount of energy that the body burns, right? Contrary to, and it's not exercise. Let me repeat that. The basal metabolic rate is the main determinant of the amount of energy that the body spends, and it's not exercise, right? It's not exercise. Any energy expenditure related to exercise can vary tremendously depending on how active someone is. So the principal determinant of energy expenditure is the basal metabolic rate. And keep that in mind. As we age, skeletal muscle mass decreases. And if skeletal muscle mass decreases, that in and of itself affects the basal metabolic rate. So it affects it in the sense that it goes down. So a reduced basal metabolic rate will reflect a loss of lean body mass. Okay? So what is abnormal nutrition? So nutrition is whatever we eat to keep the body healthy, to promote good health, and to sustain life, right? So abnormal nutrition, it ranges from one extreme, which is undernutrition, to another extreme, which is excess nutrition or overnutrition, overeating, overnutrition. This is also important. Why? Because age-related changes in physiology, in metabolism, age-related changes in function, it can affect an older adult's nutritional requirements. And that impact can lead to malnutrition, right? Bad nutrition, either under or over nutrition. Is there a gold standard? Is there a great way to measure nutritional status? Notice I'm saying nutritional status and not necessarily nutritional intake, right? Let me ask a question. How we measure, how do we measure, what's one of the better ways to measure nutritional intake in an older adult? Could be in anyone, but in an older adult in particular. How would we assess or measure nutritional intake? An easy way to do it.
BMI.
BMI, yes, BMI is a good way. It's sort of indirect, but that's a good way, and we'll talk about that. That's a great answer. So when a patient is admitted to the hospital, and the nurse is taking care of the patient, and dietary comes by and they bring the tray, how do we know that the patient ate the food?
Check the labs or albumin. I don't know.
Pardon?
Maybe albumin in the labs.
So albumin in a lab, that's a good answer. That's an option. But albumin in the labs is probably one of the least effective way of assessing accurately intake, right? And it has a lot. Pardon?
You look at what's left on the tray.
Exactly. Look at what's left in the tray. See how much they ate and how much they left over, right? So a calorie count. How much did they eat, right? And how much did they leave back? So that's one of the most direct ways to assess how much a patient ate or their nutritional intake, right? Albumin is a good answer. It always appears. It often appears on boards or other places, but part of the problem with albumin is that the albumin level and the pre-albumin level is the half-life is too short. So keep that in mind. That's sometimes one of the more frequent wrong answers on the boards. Okay, that's a board question. It's a high yield question. A calorie count is a great way of knowing how much a patient eats and what the nutritional status is. So, but we use this term anthropometric, which is a great term. It's the study of the measurements of the size and proportions of the body, the human body. And one way to measure that or one way to assess that is the BMI, as was just mentioned, right? So the BMI, and the BMI is a ratio, right? It's the mass divided by the weight in kilograms divided by the height in meters squared, right? So it's a number. And that number is important because there's specific cutoffs that have clinical implication, right? Normal, generally speaking, it's not absolute, but normal, generally speaking, is somewhere between 18.5 and 25. Okay, so if someone is tremendously below 18, that has clinical implications. For example, someone whose BMI is below 17, that can be associated with certain underlying conditions, right? And a poorer prognosis than someone who has a normal BMI. So in terms of undernutrition and some of the statistic epidemiology, the prevalence of undernutrition in older adults, outpatient, is as high as 13%, right? And when you switch that cohort to hospitalized patients or patients in an acute care setting, the prevalence of undernutrition ranges from 25 to 50%. So it could be as high as 50% of hospitalized patients. If you transition that to a skilled nursing facility, the prevalence of undernutrition, for a variety of reasons, but the prevalence of undernutrition in skilled nursing facility residents exceeds 50%. Okay, so what do I mean by inadequate or undernutrition? There's a definition, okay? An average intake of the food groups, whatever the food groups are, right? Carbs, fats, and so on, right? An average intake of food groups or nutrients, right? Or energy that is 25% to 50% below the recommended dietary intake threshold. So they're eating less than 50% or less than 25 to 50% of what's recommended, okay? And so that's considered inadequate or undernutrition. And that's important, again, because undernutrition, right, in terms of consuming less than 50% of what's required in terms of energy, right? That is associated with a higher mortality rate when you compare that to patients who take what's recommended or that's above the BMR. So it's undernutrition is associated with an increased risk of death. Okay, and lack of access to food, and that's important. Lack of access to food. Lack of access to food could mean an older adult doesn't have the ability to get to the store to access food. Or it may also mean that the older adult, although there's food in the refrigerator, may not have the ability to get out of bed to get to the refrigerator to access the food. So lack of access to food has a lot of meanings, right? Practical meanings, okay? And things we should think about when we care for the older adult with underlying medical problems. Lack of access to food is a common cause or commonly contributes to undernutrition. So it is important to determine whether limitations in resources, could be financially, could be access, limitation in resources, transportation limitations, functionality limitations, whether all of these may limit a patient's access to food or the ability to even prepare or to consume food, right? Patient may have food in the house, but no electricity to cook, okay? So we're still on the topic of undernutrition. Poor intake, poor nutritional intake may be an indication of illness, or it's often an indication of an underlying problem. Okay, it could be an issue with the mouth, you know, difficulty chewing, an infection in the mouth, an abscess or gingivitis, you know, gum problems, or a mass or something. Okay, so poor intake is often an indication of illness. In terms of maybe difficulty swallowing, okay, dysphagia. You know, I did not comment on dysphagia, even though it's in our objective. Let's talk about this dysphagia for a minute before I speak on the nutrition part. Dysphagia, by definition, is what is dysphagia? Anyone? So dysphagia, anyone? Dysphagia is difficulty swallowing.
Difficulty swallowing.
Right? It's difficulty swallowing. Now, an older adult may have difficulty swallowing for a variety of reasons. Okay, so as I mentioned, oral health is important. Poor dentition, missing teeth, gingivitis, pain, abscess, a variety of things can cause it. What would you say is if you had to make an educated guess, or you know the answer, what would you say is the most common cause of dysphagia? And let me break dysphagia down, okay? Think of three, in terms of pathophysiology, there are three different causes of dysphagia. There can be dysphagia originating in the mouth, so it's oral dysphagia. And then there's dysphagia in the back of the mouth, like the pharynx. So think of pharyngeal dysphagia. And then think of dysphagia because of what's happening in the esophagus. So think of the mouth, the oral pharynx, and think of the esophagus. So what would you say is the most common cause of dysphagia, oral dysphagia, in an older adult? And so let me help you a little bit. So if I tell you that in terms of eating, orally eating intake is a voluntary process, right? Placing the food in the mouth is one thing, and then we also have to chew the food, right? Mastication, you have to chew the food. You have to mechanically digest it or break it down, okay? And what if I tell you that that is a voluntary process? Now, what would the answer be? That what is the most common cause of oral dysphagia?
Difficulty chewing.
In the older adult, so that's a good answer. That's a good answer. Difficulty chewing could be because of dentures, dental problems, missing teeth, infections in the mouth, and so on. That's a very good answer, but it's not the most common cause of dysphagia in the older adult, oral dysphagia. So dementia, right? Dementia would be the cause of oral dysphagia. Because remember, the patient has to place the food in the mouth, and then it's a voluntary process. The patient has to chew the food and then intentionally initiate, you know, the pharyngeal reflex by passing the food to the back of the mouth. So dementia is probably the most common cause of oral dysphagia, okay? And then we can have other problems affecting the back of the throat because a lot of muscles are involved there, right? A lot of cranial nerves are involved there. So what would you probably say is the most common cause of a swallowing disorder originating at the level of the pharynx? What would you probably say that is? So any insult to the cranial nerves involving swallowing, right? Or the nerves and the muscles involving swallowing. So stroke, okay? Cerebrovascular disease or any insult to the brain that affects that region. So in terms of oral dysphagia, dementia is the most common cause. And that is why in many instances of advanced dementia, you know, patients who are fed, sometimes they keep the food in the mouth. So you return to feed them for lunch or for dinner, and they still have breakfast in their mouth. Okay. Now, in terms of undernutrition, now poor intake, right, is often an indication of illness. And keep in mind, by intake, it implies one, physically putting the food in the mouth, two, mechanically digesting it by chewing it, mastication, three, passing it to the back of the throat and down the esophagus into the stomach, four, there's also enzymatic digestion, and then five, part of the process is also adequate absorption, so that any condition impacting digestion, whether it's mechanical or enzymatic, any condition impacting motility, the movement of food from the mouth straight down, and any condition impacting absorption potentially can contribute to undernutrition. Okay? So poor intake is often an indication of illness. Can a patient with B12 deficiency, right? Can a patient with vitamin B12 deficiency, so for example, the case that was presented earlier, the older adult with numbness and tingling in her hands and feet, could a patient with B12 deficiency be taking B12 supplement by mouth, right, and still be vitamin B12 deficient?
Yes.
Anyone? Yes. And why would that be?
Inability to swallow the pills.
Absolutely. So one is inability to swallow the pills. What if I tell you that so that's correct, that's the correct answer. So what if I tell you that, oh, but she is able to swallow the pills now? Why else would she still remain B12 deficient?
Malabsorption.
Exactly. Okay. An absorption problem. Okay. An absorption problem. Thank you. So poor intake is often an indication of an underlying disease, and unintended weight loss of as much as 5% of your usual body weight in 6 to 12 months, or 10% of the usual body weight in 6 to 12 months, that's an indication of underlying medical problem, okay? Not only is it an indication of underlying medical problem, but it's a predictor of functional decline. It is associated with increased healthcare expenditure, maybe more ER visits, or visiting the doctor more, or spending more funds on you know, things to correct the problem, whatever is perceived to be you know, important things to cure or prevent the problem. It's associated with an increased risk of hospitalizations. Undernutrition or poor nutrition, it leads to unintended weight loss. And along with unintended weight loss, is the micronutrients deficiency and the macronutrients deficiency in the case of B12 deficiency, which is very common in a lot of older adults, right? It leads to a decline in cognition, decreased memory. It impacts functional status, right? The ability to execute activities of daily living, whatever they may be, okay, and instrumental activities of daily living. It leads to, so unintended weight loss leads to vitamin deficiency, micronutrient deficiency, vitamin deficiency, and it increases the risk of things like infections or pressure sores and poor wound healing. Why would that be? Can someone, what would the explanation be? How does someone with macro or micronutrient deficiency develop pressure sores or poor wound healing? How does that work?
I think one healing needs proteins for healing.
Absolutely. Nutrition is necessary for wound healing. That's one. Absolutely. Also, someone whose functional status is declining is at high risk. Anyone with a neurological disorder who's, let's say, bedbound, that's the extreme, right? Is unable to turn frequently, right? That patient is at high risk for pressure ulcer because there's tremendous pressure at the bony prominence. So the circulation to that region is not as good, right? There may be sensory problems, right? That lead to infection. Maybe the individual got cut, a tiny cut, and it's not addressed, and it leads to an infection. Okay, and so undernutrition is also associated with not only with increased risk of certain diseases, infections and pressure sores and so on, but it's also associated with an increased risk of mortality. Okay, and how do we address it? Well, if it's undernutrition, then you provide nutrition, right? But in all these cases, education is important. Education, 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 especially if the individual has, if the patient has, if the older adult has capacity. Otherwise, we engage. We should always engage family members and other caregivers, right? Education is important, okay? And then we have to supply, we have to provide adequate nutrition, food, provide access to food. And this is really good because there's an Older Americans Act, right? That promotes, right? So the Title 3C of the Older American Act, Nutrition Services Program. So it's a program for older adults. It's an act, right? It provides for nutrition, for meals to be delivered to older adults, whether at home or whether in a congregate setting. And my understanding is this is available throughout the U.S. in many parts of the United States. Okay, and this is a quote directly. Because of the Older American Act, it is believed well, adequate access to nutrition and appetizing food should be assured, should be provided for patients of various cultural backgrounds and in all settings, irrespective of their economic status. They should have access to food. Okay, and not just access to food, but it should be appetizing. It should be nutritious. It should be good food. Okay. So how do we treat undernutrition? One, we have to educate. Two, it's important to provide access to food, and that's how we prevent it. Prevention is better than cure. So prevent it in the first place by supplying everyone with food. And we mentioned just employing mechanisms to enhance the food intake, right? So if the food is tasty, if it looks appetizing and it smells good, the older adult is more likely to eat it, right? I mean, it's sort of not rocket science, right? You enhance the food intake by catering for food preferences, provide delicious, appetizing, food. It looks good, it tastes good, it smells good, and the temperature has to be adequate too, okay? And the setting is important. There's evidence to show that food intake is enhanced when older adults eat together rather than when they eat alone. So eating together may increase sociability and food intake. Okay? This is huge. Address the underlying problem. How do we treat undernutrition? If there's an underlying medical problem, treat the underlying problem, right? If there are issues with chewing, issues with the mouth, issues with dentition, someone has a cavity and a toothache, address that. Gingivitis, address that. Oral abscess, address that. Oral ulcers, address that. Esophagitis, address that. So treat the underlying problem. Okay, provide appropriate mouth and hand care. Okay, if someone had a stroke, for instance, and has a motor deficit and is unable to, if a patient is unable to feed herself, then provide a mechanism to assist her in feeding. Caution should be exercised when recommending therapeutic exercise, therapeutic diets. Don't use therapeutic diets unless there's clear-cut evidence. Again, we practice evidence-based medicine. It's not your opinion per se. It's not your feelings per se. It's not because that particular person tried that particular diet on that particular day when it was that particular temperature, and therefore I should try it or I should recommend it to my patient. Use evidence-based recommendations in terms of diet. In terms of addressing undernutrition, increase caloric intake, right? So provide, the intake should be balanced, okay? It should be a balanced diet, meaning it should have the adequate proportions of all the respective food groups, right? So adequate proportion of all food groups. So it's a balanced diet. Be careful with nutritional supplements. It is good to provide nutritional supplements. It's recommended for it to be high caloric density, lactose-free and gluten-free. And that's important. There's evidence to show that it correlates with a small but consistent weight gain in older adults. And there's also evidence to show that nutritional supplements decrease mortality in undernourished older adults. Okay, but we should be careful with nutritional supplements. The nutritional supplement should not replace, it should not be a substitute for the meals, right, with adequate essential vitamins and minerals. So caution, supplement does not replace and therefore decrease overall food and essential nutrients intake. And also keep in mind that there is no evidence that nutritional supplements really improve functional status or decrease hospital stay. And finally, in terms of supplements, there's not any significant evidence that giving routine supplementation to older adults who are at home or who are well nourished, giving it to them will improve per se quality of life and life expectancy. In terms of medication, we have to be careful. It is good to be careful. There's not a lot of evidence, there's no evidence-based reports suggesting long-term survival benefits with medication. Long-term, how do we define long-term? There's not enough evidence to support long-term survival benefits, okay? Two agents that are commonly used, periactin, which is cyproheptadine, okay, we should be careful because it causes confusion in older adults. And then I recently encountered this with a patient. Someone placed one of my patients on Megace, Megestrol, and this patient developed a PE, pulmonary embolism, okay? Megestrol increases body fat, but it does not have a significant clinical benefit. And I think more important, I mean, this is all important. More important though, is the risk of DVT and PEs, okay? Be careful not to place patients on Megace without paying attention to the potential adverse effects, including patients who may have underlying heart disease. Be careful with fluid retention, okay, and exacerbation of congestive heart failure, okay. Let's switch to overnutrition. What is overnutrition? How do we assess it? One way is to look at the BMI, as was mentioned previously. So a BMI of 30 kilograms per meter squared or greater, that is by definition obesity. BMIs above 35 is associated with an increased risk of functional decline among older adults. So obese patients potentially can have a lot of complications by virtue of being obese, right? Now, this is an important point. Although someone may be obese, having a BMI above 30 or above 35, right? That individual may still have micronutrient deficiencies because the total caloric intake may be excessive, but at the same point in time, the diet would not have adequate micronutrients, so the patient would be at risk for micronutrient deficiency. So poor diet quality and micronutrient deficiencies are relatively common in older adults, especially older adults living alone. Remember our patient, the 74-year-old female that I presented earlier. Her husband died about 11 months prior to her presentation. So she lives alone, okay? Remember that. Excessive body weight and modest weight gain in middle age may be associated with medical problems later in life. Yeah, there's a correlation, there's an association between obesity and hypertension. There's a correlation, an association between obesity and diabetes. Visceral obesity is a risk factor, a major risk factor for type 2 diabetes, right? And what's the first line treatment? Board question. What's the first line treatment for what's the first line treatment for diabetes and hypertension? What's the first
lifestyle change? A lifestyle change?
Absolutely, right? Lifestyle changes, right? Absolutely. Diet and exercise to treat hypertension, to treat diabetes. And so excessive body weight and even modest body weight. So what we do when we're younger, right? So body weight gain in middle age, it is associated with or it correlates with medical problems later in life. So it's good to start advising even our younger patients or younger adult patients to be mindful of their weight, because there's an association between obesity and hypertension, diabetes, heart disease, even sleep apnea, certain forms of cancers, and osteodegenerative arthritis, right? Obesity is associated with impaired functional decline. It's associated with increased healthcare expenditure. By virtue of being more obese and having more underlying medical problems, it makes sense that, there's going to be an increased utilization of healthcare resources, right? And it's associated with increased risk of mortality, even cardiovascular disease, cerebrovascular disease, heart attacks, strokes, kidney problems. So how do we treat obesity? Education, always education. Educate the patient, educate the family, educate the members of all the caregivers, okay? Educate them. Education is important, okay? And encouragement. There's evidence to show when the recommendation comes from a healthcare provider, it carries a lot of weight, okay? When the directive comes from, a healthcare provider, okay, not just a physician, a healthcare provider, an NP, a nurse, okay? It has a lot of weight, okay? And so if the issue is obesity, then we have to lower the caloric intake, right? While at the same point in time, maintaining a balanced diet, right? Balance in terms of the right proportions of each food group. In terms of exercise, it's kind of hard to give certain recommendations. So I usually tell my patients, stay physically active. I usually say an hour a day. I usually say an hour a day. Keeping in mind at the back of my head somewhere, I'm saying, okay, he or she may not do an hour, but if they give me 30 minutes, I'm happy, or even 20 minutes, I'm happy. So I recommend an hour at the high end and hope that I'll get something. I say 5 days a week. I'm happy to get at least 3 days a week. But the recommendation is moderate intensity aerobic physical activity, or physical activity relative to what the patient is able to tolerate, right? So 150 minutes per week, okay, spread out over the week. stay active. And there is benefit to doing some kind of muscle strengthening exercises, okay, twice a week. So in terms of the first question, which of the following is a sign of aging? Increase in pigmentation of hair, increase in bone and muscle mass. We kind of covered this. Increase in body fat content and intra-abdominal fat stores, increase in kidney function, and then I'll put E in terms of increase in esophageal motility. And so the correct answer will be C, increase in body fat content and intra-abdominal fat store, because all the others should be decreased. Decrease in swallowing ability, which is normal to some degree, right? The normal quote unquote peristalsis is slowed, okay, as we age. There's a decrease in hair pigmentation, there's a decrease in bone and muscle mass, okay, sarcopenia is the term, so skeletal muscle mass decline, and there's a decrease in kidney function and creatinine clearance. That's important again, because a lot of medications, particularly water-soluble medications, are eliminated. They're eliminated, a lot of them are eliminated at the kidney level, right? So if there's an impairment in kidney function, concentrations of those medications can be increased in the body, and they can have exaggerated effects or dangerous effects in the body. So we have to adjust the dose. We have to adjust the frequency of prescribing those medications, okay, for the older adult. And this is a great case. Keep it in mind. You guys can have access to this again. 74-year-old female. She has a history of hypertension, diabetes, and degenerative arthritis in both knees. She presents to her PCP 11 months after her husband's death. So we have to think of depression, even though the time frame, 6 months, 11 months, we have to keep that in mind, the time frame. What is normal grief versus what is abnormal grief? Keep those things in mind. She lives living alone, an elderly living alone. That's a warning sign. She gets 2 to 3 visits per week from her children and members of her local church. She reports a 2-year history of knee pain. Okay, knee pain is important without associated joint swelling, tenderness, redness, warmth. That's inflammatory arthritis. She does not have inflammatory arthritis such as rheumatoid or other inflammatory. She also reports numbness. So this is neuropathy in her hands and feet. Okay, think of the differential for that, not just micronutrient deficiency in terms of B12, but think of related to neuropathy from diabetes or nerve impingement at a higher level. And feet, so numbness in feet. 16-pound weight gain. She's gaining weight, but is her diet balanced, right? She laughs appropriately, that has meaning. Her BMI is 37. She has a good mood. Her BMI is 37. She uses a rollator with seat to walk. So her history and physical exam is associated with which of the following? So because of all these underlying issues, she has an increased risk of functional decline. That is true. She also has an increased risk of utilization of healthcare resources and an increase in this, healthcare expenditure. That is true. She has an increased risk of increased mortality rate risk. That is true. And poor diet quality and micronutrient deficiency is associated with obesity in older adults, and that is true. So all of the above is correct. Okay, I'll open for any questions or comments at this time. Any questions or comments? Anything in the chat? I can't see it. Anything in the chat?
Thank you, Dr. Perspire. That was wonderful presentation as always. There are no questions in the chat, but we can wait a couple of minutes, and please, this is a good time to ask the question.
So thank you guys very much. We have to transition to the next talk. Victoria, you want to give some guidance on that, please?
Sure, thank you, Dr. Perspire. So in the chat, there is 4 p.m. didactics link. Please use that link to go to our next bridge interprofessional session, and we will be having Clivia Torres, our wonderful clinical social worker, presenting our next didactics. Thank you, Dr. Perspier.
Thank you guys. It's a pleasure.